Hello everyone, welcome to Dr. Shravani's Med Concepts. Today's session will be on atypical ductal hyperplasia. As per WHO classification 5th edition, we will have an entity known as epithelial tumors of the breast, under which we will have benign epithelial proliferation and precursor lesions. Atypical ductal hyperplasia is one among them, along with usual ductal hyperplasia and columnar cell lesions including flat epithelial atypia. Atypical ductal hyperplasia will have 3 to 5 fold increased risk of cancer. Coming to definition of atypical ductal hyperplasia, it is an epithelial proliferative lesion with cytological and architectural features similar to that of low-grade ductal carcinoma in situ. But these features are less developed in architecture, degree of terminal duct lobular unit involvement, and contiguous extent. Coming to the microscopy of atypical ductal hyperplasia, there is intraductal epithelial proliferation, which is partial and uniform involvement of duct space involvement. It consists of monomorphic cells which are uniform in size and shape, and the cell borders are well defined. They are evenly spaced. So all these are the characteristic features of atypical ductal hyperplasia. There is intraductal epithelial proliferation, partial involvement of the duct space, and the individual cells are monomorphic, means they are uniform in size and shape, well defined borders, and evenly spaced. Coming to the nuclear features, in atypical ductal hyperplasia, the nuclei are monomorphic, means they are similar in morphology. So all of them are round to oval uniform nuclei. So these monomorphic nuclei suggest a clonal proliferation of atypical epithelial cells, which is a step closer to malignancy when compared with UDH, that is usual ductal hyperplasia. So in usual ductal hyperplasia, there will be polymorphous nuclei, means each nuclei will not be mimicking one another. So there will be variation in the size and shape of the nuclei. So atypical ductal hyperplasia, monomorphic nuclei; usual ductal hyperplasia, polymorphous nuclei. So these are the characteristic features regarding the nuclear features. Coming to the polarity, in atypical ductal hyperplasia, the cells are well polarized, means they are aligned along the luminal edges. So, polarized cells in atypical ductal hyperplasia suggest neoplastic process, whereas in usual ductal hyperplasia, there is loss of polarity. UDH lacks this polarity. So, polarization is maintained in atypical ductal hyperplasia, whereas the polarity is lost in usual ductal hyperplasia. Coming to the architectural patterns seen in case of atypical ductal hyperplasia, first one is Cribriform pattern. So here you can see the Cribriform pattern in case of ADH, which mimics cookie cutter appearance. Next pattern is rigid bridges and bars. The cells are arranged in the form of rigid bridges, bars, arches and arcades. Third pattern is micropapillary pattern. In this pattern, the base of the papillae will be very narrow, whereas the apex or the tip will be broad. This is in contrast to the UDH. In UDH, the base will be very broad, whereas the tip will be narrow. So this type of micropapillae, in case of atypical ductal hyperplasia, they resemble club shaped or mushroom shaped, and these are known as bulbous micropapillae. Other pattern is solid pattern. So the entire or partial duct is involved by the solid proliferation of the epithelial cells. So this is illustrative diagram of solid ADH. Other can be mixed, means all these patterns are present in one duct, that is known as mixed type. So cribriform pattern, rigid bridges, bars, micropapillary pattern, solid pattern and mixed pattern can be there in case of atypical ductal hyperplasia. Coming to the first pattern of ADH, that is Cribriform pattern. In this, the cells show polarization around extracellular lumens within the proliferation. So here you can see atypical ductal hyperplasia with cookie cutter appearance. So in this, there are rounded punched out lumina which gives cookie cutter appearance within the ducts. As we can see here, the dove is evenly flattened and circles are methodically spaced and cut into uniform sizes and shape with a cookie cutter, hence the name cookie cutter appearance. So here you can see the H&E image of cookie cutter appearance, that is cribriform pattern. The lumen are evenly spaced and uniform in size and shape. So this is the higher magnification view. Rounded punched out lumina are seen which gives cookie cutter appearance. Next is bridges and arcades and arches. So what are rigid bridges? They are thick epithelial bands composed of cells which traverse the duct space from one side to the other. In usual ductal hyperplasia, they'll be very slender, but in case of atypical ductal hyperplasia, they'll be very rigid. Coming to arches. Arches are curved epithelial projections forming partial loops, and arcades are of uniform thickness. They are evenly spaced epithelial structures forming looped or bridging patterns, more structured than those seen in UDH. So here we can see rigid bridges of cells traversing the duct space, and these are the arcades of uniform thickness, and arches are seen. Coming to the third pattern, that is micropapillary pattern. So as we can see here, in ADH we'll see bulbous micropapillae, which is it is similar to the UDH, that is usual ductal hyperplasia. In ADH, bulbous means the base will be very narrow, whereas the apex will be broad, giving club shaped or mushroom shaped appearance. So the micropapillae, they are typically broader at the tips than at the base, that is club shaped. So here we can see the bulbous micropapillations which are club shaped. So this is the final summary of the architecture of the ADH. So the various patterns are Cribriform, rigid bridges or bars, micropapillae, solid or mixed. In Cribriform, we'll see cells show polarization around the extracellular lumens within the proliferation, forming rounded punched out lumina, that is cookie cutter pattern within the ducts. When we see the rigid bars and bridges, they are uniform thick cellular bridges spanning the duct, often arranged in arcs or bars that are more structured than those seen in UDH. Micropapillae that are typically broader at the tips than at the base, that is club shaped. Solid, that is duct completely filled and limited in size, that is less than 2 mm. Mixed, combination of above patterns in the same focus. Myoepithelial cells are preserved at the periphery of the duct in case of ADH, as we can see here. And occasionally we will see microcalcification in case of atypical ductal hyperplasia, which is another classical feature of ADH. The difference between ADH and DCIS is only the size. The size matters. ADH is diagnosed when the lesion is less than 2 mm or involves less than 2 contiguous duct spaces. Larger lesions with similar features involving greater than 2 mm or greater than 2 duct spaces are classified as low-grade DCIS. So, involving less than 2 contiguous ducts or measuring less than 2 mm in greatest dimension, we'll call it as atypical ductal hyperplasia. When it involves greater than 2 mm and greater than 2 contiguous duct spaces, we'll call it as low-grade DCIS. Otherwise, all other architectural patterns, morphology, everything is the same. Only the size matters, differentiating ADH from DCIS. How we should approach a case of ADH? Step 1 is you evaluate the cytology, whether the population or cells are following low-grade monotony. If they are following polymorphous population, it means that it goes in favor of usual ductal hyperplasia. Step 2 is evaluate the architecture. So if they are monotonous population, what architectural patterns you are able to see? Rigid bridges or arches, bulbous micropapillae, polarized spaces or microacini, giving cookie cutter pattern, or solid. But if it is solid pattern, you should exclude E-cadherin positivity. If E-cadherin positivity is there, it means that it is ADH. If E-cadherin is negative, it means that it is atypical lobular hyperplasia. Then step 3 is you evaluate the extent of involvement. If it is following the non-uniform involvement of the duct spaces or uniform involvement of the duct spaces which is less than 2 mm or less than 2 contiguous duct spaces, then it is atypical ductal hyperplasia. So monotony, following rigid bridges, arches, bulbous micropapillae, cookie cutter pattern, E-cadherin positivity with solid pattern, and non-uniform or partial involvement of the duct spaces or uniform involvement of the duct spaces which is less than 2 mm or less than 2 contiguous duct spaces means it is ADH. If it involves greater than 2 mm or greater than 2 contiguous duct spaces, it means that it is DCIS. Coming to the immunohistochemistry pattern in case of atypical ductal hyperplasia. Atypical ductal hyperplasia is because of monoclonal proliferation of luminal type of epithelial cells. So here you will see only luminal type of epithelial cell proliferation. Hence, it is positive, that is uniformly or diffusely positive for ER, which is a luminal cell marker, whereas basal cell and myoepithelial cells are absent in case of atypical ductal hyperplasia. Hence, in this case, we'll see CK56 negativity, which is a myoepithelial cell marker. Coming to the summary of atypical ductal hyperplasia is intraductal epithelial proliferation with partial and uniform involvement of duct spaces. Here the cells are evenly spaced, monomorphic with well-defined cell borders. There are rounded punched out lumina giving cookie cutter appearance within the ducts, that is known as Cribriform pattern. There are rigid bridges of cells traversing the duct space. Arcades of uniform thickness and arches forming partial loops are seen. Bulbous micropapillae, which are club shaped and that are typically broader at the tips than at the base, will be seen. ADH is diagnosed when the lesion is less than 2 mm or involves less than 2 duct spaces. When the size is greater than 2 mm or greater than 2 contiguous duct involvement, it is DCIS. Diffuse positivity for ER will be seen and CK56 negativity will be seen in case of ADH. Here we conclude atypical ductal hyperplasia. I hope this session has been useful to you, and if you feel that it has been useful, please like, share, subscribe and comment in the comment box. Thank you.